This morning, I'm going to introduce Dr. Fructuoso Irigoyen. Dr. Irigoyen is a physician advocate and administrator at the Doctors Hospital at Renaissance. He is certified in psychiatry by the American Board of Psychiatry and Neurology and currently acts as present IMG rep to the APA Assembly, as well as having been recently elected board member of the American Society of Hispanic Psychiatrists. Dr. Irigoyen, thank you so much for being here.
Thank you very much. I think I have a very difficult task right now after this last lecture. And I guess get started, right? Last year I was not counting with staying longer in this world. I'm very glad to be here this morning with you guys. This is a very exciting opportunity. Well, this is the book Esther was talking about, and I use it as coming from that little goal, Diagnosing Alzheimer's disease and other dementias, past and future. And this thing should say here, past, present, and future, but, you know, for short. This is me. You'll see in your program that somebody added an R and an O to my name. It's Fructuoso. Made it a little bit more difficult. Let me tell you something about that. You know, I signed with LinkedIn, this social professional, and I use my name. That name, Fructuoso, and I couldn't get friends. I signed again with my nickname that is Tocho Irigoyen, and now I have friends all over the world. So that says something about that. I work right now with Doctors Hospital Renaissance, and I'm called Physician Advocate Administrator. I'm not sure what that means, but I'll be very happy. Let me do a disclaimer after what Dr. Lee said about experts. Yes, I have a PowerPoint, but I come just from 2 blocks away, so I'm not really an expert. And this is the place I come from, Renaissance Behavioral Center. Okay. You know this guy? Gordito, chubby. This is Dr. Louis, or Alois, Alzheimer. And this is his family. This is his second wife. Very interesting relationship. He was a Catholic fellow, and she was Jewish. Both of them are buried in the Catholic cemetery in Berlin. And there are still some of his descendants. And this is again our friend Dr. Alzheimer, and he is in training. And this guy is Dr. Kreppelin, the one that invented schizophrenia, the guy invented bipolar disorder. Those are. This guy here is Dr. Jung, that is also very common. Well, see, this is the past thing, okay? 1906, Dr. Alzheimer's published this paper in which he described the first case of Alzheimer's that we have noticed of. The name of this lady was Augusta. And really, there has been a debate as if she already had Alzheimer's. Well, you know, the description is so precious that you would say, well, this person does have that. And here we come to the topic of things. You know, I took this from this book. This book I recommend you to read, Physics of the Future. You want to know what's going to happen in the next 50 years, or have an idea. This is a prophet. But he says that predictions that we make are not unreasonable because most of the things that we're going to see in the next 50 years are already here. We're just seeing the development of those things. So basing that model and getting just what refers to Alzheimer's, I say past diagnosis. And let's see what is this. In the past, there were many things that would look like Alzheimer's that needed to be diagnosed first. Why? Because they were killers. For example, this one, paralysis, progressive general paralysis. That was syphilis of the central nervous system. Practically 75% of all the beds in state hospitals were filled with people that had this thing called tertiary syphilis. It's one infection of that doesn't exist any longer, luckily. This one went away with the invention of vitamins, so it's not a differential diagnosis any longer. But you'll find in the old, even in my booklet, you find that Alzheimer's cannot be diagnosed with precision except by the autopsy. That's still true. But every day we diagnose more people just with the symptoms they have. So you will see that in the present, the diagnosis has become an inclusion diagnosis. This is, we diagnose Alzheimer's first, and then we worry about they may have something else or something different. See, the main instrument, I think this is the main instrument today, and it will be the main instrument to diagnose Alzheimer's disease in the coming years, is the clinical history. We use this system mostly to diagnose Alzheimer's. This is the most commonly used diagnostic system. What is in DSM-4-TR. We'll see that in the next. And we are resorting to what I call simple imaging, as compared with what is going to come later, to complement or to finalize our diagnosis. In the near future, we are aiming for early diagnosis. What Dr. Thies was saying, this is, we have to diagnose people when they have the the mild cognitive decline, or that we'll talk a little bit more about that. But we have to get people earlier diagnosed so we can do something for them. Advanced imaging is the other thing. This is the same thing here, but actually the newer techniques that are coming and are being developed. He spoke a little bit about biomarkers. This is going to be a big thing in the future, especially for some things that we'll be checking. Genetic testing. Genetic testing is out there. You can get the APOA gene measured and several things, but still doesn't have a practical use. Possibly we'll see some practical use. As opposed to the present that we have DSM-4, this is the new thing coming, DSM-5, that is in the near future. Actually, DSM-5 is going to be released this year in May at the American Psychiatric Association annual meeting. And we're going to have to learn a lot of new names to replace, put people in different places that they are right now. In the far future, we foresee predictive diagnosis. What he was talking about, this is figuring out people that are not even in the pre-symptomatic stage, people that may have the disease. Why? Because they have certain genetic markers. Kako says in his book that people are going to be carrying a CD with their genomes all over the place, and so when you get to a doctor, you give your CD and they can see the genes and they can tell you what you may have. I don't know if that is. And finally, I'm going to mention this thing of the certainties, because I think it's something that may or may not come up with as an important thing in the future. Let's start by the past again. This is Alzheimer's. He described these cerebral changes in patients with dementia. Inside the cells, he found the fibrillar tangles. Remember talk about something called the tau thing? This is known since 1906. It was not called tau because they have not baptized that protein yet. And outside the cells, he found the amyloid deposit. So Alzheimer himself, the doctor, this chubby guy, found these things that are still, what we know about disease. Even today, this is correct, and this is, we know a little bit more, but we know what Alzheimer's really. Inclusion diagnosis. Clinical history, this continues being the most important, and will continue being the most important. I'm going to spend more time in this than in any other thing, the clinical history. As our doctor was saying in the last lecture, we never know when Alzheimer really started in a person. What did the Alzheimer's disease? But if you find all records, you'll find that Mr. Jones had told his family doctor 10 years ago that he was forgetting things. We can use this historical information to find out how long this guy has been sick. You know, needless to say, for example, when you're a psychiatrist and you're seeing people with depression, etc., we see people that actually came to me as having anxiety or depression, and they remained my patients for a long time, and then I started seeing problems with their memory. Many times I have started even treatments for Alzheimer's disease without having diagnosed it. So reading the whole record can be very important to figure out, you know, when this person started that. The mental status examination, of course, is a part of the clinical history. Neuropsychiatric testing tends to be used at times a little bit too much, and then we forget about it. It results cumbersome for a person that has, you know, the Alzheimer's disease already diagnosed to have neuropsychiatric testing. But it's going to be an instrument that tells us who is getting there, who is having certain deficits, especially for focal deficits. Focal, but let's say, but this means abstraction. I mean, that means finding words, etc. Neuropsychological testing can be very valuable. Laboratory has been confined to rule out other conditions that may look like Alzheimer's. But recently, this genetic testing that we have mentioned is taking a place there. Imagine, I'm going to spend a little time on this to show you what can we do with our local resources. According to the present classification, Alzheimer's disease is defined by having memory problems. What is this? Memory refers basically to the ability to recall things, and people with Alzheimer's disease usually have problems recalling what happened this morning. They're very good to tell you what was the name of the teacher in second year of elementary school, but they cannot tell you who came to see them this morning. This is the first kind of memory thing. DSM-4 requires that in addition to memory problems, people have one of these things. Horrible names, right? Aphasia. That clearly in Alzheimer's just means problems with communication. Apraxia, that is possibly the most common stereotype that we think about Alzheimer's disease when they put the, you know, the sock in the hand or the wristwatch on the ankle or the underwear on top of the regular clothes, etc. Agnosia is the ability of people of naming things. And there's a particular type of agnosia that I would like to hammer on here, that is called anosognosia. This is noso is noso means disease. They don't know that they are sick, and they don't know that they have illnesses. So when a person with advanced or moderate Alzheimer's disease has a pain, sometimes they hit, they scratch, they yell. They cannot tell you it hurts you. That's one of the main problems in taking care with people with Alzheimer's. They don't tell you what is happening to them. Of course, executive function decline is an important thing. We have to see, to make a diagnosis of Alzheimer's, that these things are represented by a person abandoning the things they are good to do so. What do I use here in the Valley to assess executive function? I ask a question about las matas. You know what las matas are, right? Plants. If a person used to water the plants and they don't, people can let people, kids die in parking lots or let them starve, but they will always water the plants. When they stop doing that, is that definite decline on executive function. All illnesses in DSM-4 require that people were working before better than they are right now, and this is typical of Alzheimer's. We very rarely know when it starts. Many times we see people who go through years of mild cognitive decline, and finally they start having more clear symptoms. Slow. Sometimes, I see this patient that I saw last year and say, do you notice any changes, doc? Doc looks about the same. There's a period in Alzheimer's that it goes so slow that you think even that the medicines are working. You think that your treatment is so good that the person is not deteriorating because of that. But remember, the disease, the real Alzheimer's, goes slow. Progressive, yes, you figure out that person is, you know, every, let's say, 6 months or so, you find some decline. As I said, let's go over the clinical history. The first things are difficult to pick up. Very mild, very bad, forgetfulness, memory loss. And that lady was asking, well, you know, people forget things when they're old. Yeah, we forget things when we are young. But perhaps we have more resources to, you know, to come up with something to fill the gap. And perhaps we don't realize, but you know, it is difficult. Repeated questions. This is you know, one of my favorite symptoms to diagnose Alzheimer's. When people are asking, is it 5 o'clock? Is it already 5 o'clock? Are we going to eat? Are we going to eat? We have a problem there. And sometimes, you know, I already told you. Oh, okay. If we are harsh enough, possibly we'll let the person with Alzheimer's stop asking the question. But usually that happens in the very early stages of the illness. Some trouble using words. But see, this is the same thing that we saw with the DSM-4, but in kind of a more, you know, regular type of English thing. You know? Memory loss, difficulty performing tasks. This is the things that I always do are more difficult to accomplish right now. Problems with language, disorientation in place and time. Do you know what time is it? Well, I never put attention to those things. Okay. Normal people know the date. When you ask the date, and people don't know, there's something wrong. People can tell you, you know, the wrong date by 1 day or two, no big deal. Okay. People can do what the doctor did and say, what was it? The day for that symposium in Washington? Okay, it's okay, but you have to have an idea of where you're at. Poor or decreased judgment. People are taken to my consult after 2 times that they have been lost. They take the car and the police brings them back and they don't know where they are. Okay. People are taken to my consult when they confuse one person with another. People are taken to my consult when they put their shoes in the fridge. And you know, in all of those instances, it is too late. Unfortunately, but oh, sorry. This is difficult to assess, but if you have a more or less a structured conversation with the patient, you'll find that they are every day more kind of using the thing to, oh, this is not a pen any longer, this is a thing, right? The thing you write with, this thing you have in your hand. Like things don't have names anymore, but they all become the thing upon the thing. Changes in mood and behavior. 2 things are important about this. One is that many people that have suffered chronic depression actually develop Alzheimer's disease, much more than people in the regular population. And second thing is that dementia comes with, well, you realize that something has happened to you and you get depressed upon that, or you get anxious about the things that you cannot communicate with other people, or basically you try to avoid interaction so people are not criticizing you because you're not any longer a functional person. Changes in personality. In this one, there's some debate. Says if you have been an SOB as a young person, you're going to be a worse SOB when you have Alzheimer's. Okay. And this, of course, is connected with everything else. So this is, in plain English, what DSM-4 put with these difficult words: aphasia, apraxia, and agnosia, right? And decline in executive function. What happens later? And this is just important because The second most common illness in the group of dementias is muscular dementia. And muscular dementia is kind of different in several ways. It's like people with muscular dementia, you diagnose them and you see them 1 year later and they have no changes, unless they have had more little strokes. That's the reason that this goes by leaps and bounds. Alzheimer's disease goes very, very slow. I have to insist on that. Still in the present, we'll see a little bit of what we know. This is an MRI of a person with Alzheimer's disease. You see that you can see, you know, this thing, what we call the apraxia, you know. Yes, unfortunately, we don't have anything as good as that yet. But we have this wonderful techniques. This is a routine thing that is done here in San Antonio, here in McAllen. This is basically a combined MRI that put some color to make it a thing. Notice here, these little 2 dots, those are the ventriculi, these are normal ones. This is the size these places filled with cephalospinal fluid are. You'll see that the brain is neatly packed and there's almost no empty space. These little sulci are called, these are just little things, and this is therefore a normal brain. Let's see how this changes when you get Alzheimer's disease. Remember the ventricula, they were very little spots? Now they are big, big, big things. This is full of fluid. You know, some people think, okay, is that the fluid here is increasing? No, no, no. The brain is shrinking. And you can see that also in these little sulci that become more prominent as the illness advances. Of course, this is a quite advanced thing. Muscular dementia, you see basically the same thing. I don't know if it's clear here enough. This arrow is pointing to an area that is really a stroke. If you look carefully, you'll see more here and here and here. So it's the same picture, but you can find little spots that tell you that there has been a stroke there. Finally, sometimes you make a diagnosis of Alzheimer's disease and you study your case more carefully, and you find that it was not Alzheimer's. This is a big tumor that actually is pressing the brain to the sides. And this guy, a 90-year-old fellow, was taken to me because he had Alzheimer's. Was already diagnosed in one of the important clinics up north. Say, hey, there's something else here. And actually, yes, there was a big tumor. The tumor was removed, and the patient got somewhat better, but you know, the tumor had been there for so long that many changes were permanent. This is today. We have figured out people with diagnosed dementia, close to 80% of them have Alzheimer's. Some of them have the variety of called Lewy body dementias that is a little bit more, perhaps more symptomatic. People have hallucinations, they have early disorientation, etc. And many times this comes in tandem with Parkinson's disease. There are rare dementias that I think is important to differentiate from Alzheimer's, because in the near future we want to be able to treat better some of these conditions than actually we are going to be better, better to treat Alzheimer's. And we go to near future. What is this? Early diagnosis. We hope that things like this, symposia like this, are going to be very important, so we are alert and we diagnose this thing at the very first symptoms. And the doctor was saying it's important to get to the pre-symptomatic stage, and if not, at least in the mild cognitive. Oh my goodness, that was a striking effect. In the future, we see more, complex types of. We see the same, basically the same changes, but in this particular type of imaging, this has been assisted by computers and by special dyes, etc., so you can have a clear idea of what areas of the brain are actually affected. they're functional imaging like this, that actually you can see the part of the brain that is not working, while the whole brain, you know, looks kind of normal. You find in this case that is a quite early case, because you see the whole brain is working well except this little section here in the temporal lobe. Perhaps this is the newest thing in that we've already seen happening. They're finding these biomarkers, and basically they give you some substance that you drink or they inject you, and the area that's having problems in your brain shows up in the MRI with a different. Just a couple of weeks ago, the FDA approved this one to be used, and I expect these techniques actually to come closer to us very soon. The idea here is that we can detect places where this amyloid thing is deposited, and also detect places where the other substance that mentioned, that is the tau protein, are deposited. We're going to have technology to do that. Genetic testing. This is already done. You can go to a lab and request to check if you have the gene for Alzheimer's, or you have several of those genes, etc. And actually, it seems to be useful in late AD. And changes in chromosomes 14 and 21 are being tested in some places. And this is to diagnose people, say, what is maybe happening to this person, or perhaps they have the gene for Alzheimer's. See this? This is the official name of Alzheimer's disease according to psychiatry. Senile dementia of the Alzheimer's type. We have this thing coming. Be ready to change your names. Dementia is a bad word. Well, nobody likes to be called demented. You get dementia, etc. Well, so it's not politically correct. So they came up with this thing, neurocognitive disorder. Okay. You know what I think is going to happen to this? This is not that the predictions for next future, that we're going to end up calling this thing MNCD. Like we call ADD, it has a horrible name, attention deficit hyperactivity disorder. Like we call that ADHD, right? We're going to call this thing MNCD. That's my prediction. But still, the name of Dr. Alzheimer is going to be tied to this. It's going to be Alzheimer's disease type. What about the other condition that Dr. Thai mentioned? This is the benign cognitive decline. That's going to be called minor neurocognitive disorder. So we're going to have one condition with capital M, and the other one with the small m, minor and major neurocognitive disorder. We expect this to happen this same year, because the new DSM-5 is there, unless they repaint it and they change it again, because nobody knows what is going to be in DSM-5 until DSM-5 is released. Near future. Hey, what happened? Dr. just mentioned the NAPA, but now there's another thing. It's called the BRAIN program. The Obama administration is expected to do what the Clinton administration did with the genome. Remember that they made a big fuss about now we can map all the genes a human person has. That's the word, not human person. Okay, but now the same effort is going to be done by the federal government, and this is going to include the military, very important. Military is always kind of ahead in these things, and you want to be able to do these horrible mysteries of Alzheimer's disease, and also Parkinson's, and also anything that is on the way. There are millions and millions of dollars committed to this program, which is very good, I think. This is the official logo for this new campaign, Brain Research Initiative. The other one was NAPA, right? And this is going to be BRI. There may be money for some of you guys there, so keep an eye on this. What about the far future? I'm thinking here the definition far future is like 50 years in the future. Diagnosis isn't going to be early, it's going to be predictive. This is, we're going to be able to diagnose people to have a higher probability than the rest of the population to have Alzheimer's disease. Luckily, we will have you know, the genome of every person in a CD, as CACO pretends. And we're going to be able to do this, that this is possibly the most important thing. You know, have a person with clear Alzheimer's disease, and you see the genetic mapping of this person, and you compare that with your own. You say, oh my goodness, I have 2 or 3 points that I look like this guy, so I may have this problem. And I'm going to finish this with this, I think this is an interesting series of discoveries. This guy, Sinclair, was looking for genes that would explain why some people live less than others. You know, this is the length of life, but also why people get old and have all these symptoms and signs of getting old, you know, shrinkles, memory problems, etc. And all this on. And they found in rats these genes. They progressed to, but this, they found that there's a protein that actually triggers these genes to work. And they discovered these things that is chemicals activating certain systems. They came up with this really interesting one. This has to do with what is called the French paradox. You know what is that? In France, people cook with olive oil. They eat all this good stuff that is bad for our brains and for our health. And actually, they live longer and possibly they have less problems with dementias and stuff. So some people are recommending, you know, to drink more wine because resveratrol is in the wine, and this is called the French paradox. We don't know how important this is, but it sounds like it's one of the things that, according again to our future predictor, if this can protect mice from a variety of diseases, including lung and colon cancer, melanoma, lymphoma, type 2 diabetes, cardiovascular disease, and Alzheimer's disease, maybe there's something here for us. With this, I conclude the presentation for this morning. This afternoon, I'll be talking about behavioral disturbances in dementia, and possibly try to answer more about the question about antipsychotics and stuff like that, because that's a central part. I would like to thank you for your attention, and if you have any questions, this is the time before Alzheimer's.
Dementia. And needless to say, I have a couple of them, so I'm kind of scared, and I'm only 30, and I'm like, uh-oh. So I kind of want to know, what is the range, like, is it 50 and above, or have you had cases where they're younger?
You know, unfortunately, there's kind of a double jeopardy kind of thing sometimes for people. You know, people that have Down syndrome have a tendency to present Alzheimer's at a much earlier age. You know, I've seen, especially people with Down syndrome, and also in some other forms of mental retardation, typical Alzheimer's developments in people that are just 25 or 30 years old. The original description, Alzheimer's disease, actually applied to people that were in their 50s. That's why, you know, I said the correct name of this disease is senile dementia of the Alzheimer's type, because we're talking about the age population. But the real early dementia is something that happened in the 50s. Finally, Dr. Thai mentioned when you're 85 years of age, your chances of having Alzheimer's are 50-50. 90-year-olds, possibly 2 out of 3 people have Alzheimer's. Yes, you know, age is the most important risk factor for Alzheimer's. When does it start? As I was saying in my lecture, we're not sure this person can have the first symptoms 10 years ago or something like that. But, you know, in the age range, chances are when one is 60, like me, 64, chances is possibly 1 in 100 people have already Alzheimer's at 60. At 70, it kind of tripled. And at 80, as I said, is 1 in 2, and possibly 90 is 2 in 3. That's the general statistic. I think the important, let's say, commitment that we have to do as responsible persons is no matter how many symptoms we have or what is our genetic load, etc., we have to try to follow recommendations that were just given to us, exercise, type of thing, try to have a good health. You know, there's latest study is this correlation between high blood pressure and Alzheimer's. The fact is that if people treat their high blood pressure, they have a lower chance of getting Alzheimer's. Why? We don't know. Where's the connection? The blood pressure actually hurts the brain. That is a matter of speculation, but actually, if we have good general health, and not like this guy that is talking right now that he lost a leg because cholesterol problem, the thing is that we have better chances of not getting you know, Alzheimer's or even the. We'll see lots of changes coming in this coming years, since more people are going to be recognizing that they have the initial symptoms, like what is called now mild cognitive decline, and are going to be looking for what is happening already. You know how many people go to me looking for a prescription for Aricept. Say, but you have to have Alzheimer's disease to be prescribed Aricept. No, doctor, you know, I think I know somebody that is taking it already. So these pills for Alzheimer's are becoming what was called smart pills. And so people are taking that to improve their memory if they are having problems with memory. Not necessarily going to work, but some people report good results to that. As a matter of fact, one of my other predictions is that once that the marvelous immunoglobulins are out, etc., that kind of thing, drugs like Aricept are going to continue alive because regular people like you and me are going to be taking it to improve memory. Any other?
Well, what happens if they're taking that medication now just because they want to improve their memory, but what happens when they actually do develop the disease? What happens when they do finally develop the disease? I mean, is that medication going to be like, are they going to be immune to it, to where it's not going to work? Kind of like people were taking ibuprofen, they have a headache, they kind of start increasing the dose because, you know, that's how they started off. They started getting immune to it. Do you understand my question? Like, is that what's going to happen with this medication too? They do that?
Yes, I don't think I have an answer for that because, you know, actually it's happening. People are taking medications when they are not diagnosed, or we doctors sometimes say, well, this person has a diagnosis of depression, etc., that kind of thing, but let's give him a little Aricept or something like that. The same company that makes Aricept, you know, had said Aricept is prescribed 5 milligrams, is prescribed 10 milligrams, and now they came with a 23 milligram tablet. Why? Because they have kept, you know, researching how can we give more? Is more beneficial? They came up with the conclusion that possibly 20 milligrams is better than 10 milligrams. And there's a debate that if that's the case or not, but the pharmaceutical company is.
Well, of course, they're not going to discourage them.
Sure.
For their benefit. But
Sure, but you know, people using it as kind of a preventative, and well, that's happening right now. And I don't know, you know, I see just a little piece of the universe in my office. I don't know, you know, how important this is nationwide or worldwide. But I can tell you it's happening because I have seen it with my own eyes that there's people coming and asking for particularly Aricept.
Dr. Irigoyen, could you please speak a little bit to the importance of treating the family, when treating a person with Alzheimer's, working with the family and involving them in the treatment?
It's an absolute imperative. You know, I had to slice my presentation to present only diagnosis of Alzheimer's disease, but actually the diagnosis of people taking care of people with Alzheimer's is as important as the diagnosis of Alzheimer's. It has been demonstrated that the level of free cortisol, for example, that is a marker for stress, is as bad in people taking care of an Alzheimer patient than it is in people with post-traumatic stress disorder just coming back from Iraq. You see, why people can get that stressed? Okay, it's very, very important. We're not going to diagnose Alzheimer's disease in the relatives of the people. Now, one of the big questions that has to do with diagnosis is, my dad has Alzheimer's disease. What is my chance of having Alzheimer's disease? There are a few cases that actually you can come up with a probability. In many other cases you have to say, just, I don't know. Why don't you do the genetic thing and let's see if we can approximate more and answer a probability for you. But I don't see that doctors or counselors are in the business of predicting what is going to happen to people that don't have anything to show what they can see yet. But I think I see a big role in counselors and doctors in kind of helping people understand what's happening with that. You know, it is what I call the nursing home syndrome. This is once you're diagnosed with Alzheimer's disease, this is it for you. Well, that's the time when one has to go closer to that relative and ask questions, Can you tell me about my aunties? I can't tell you where I come from. What is the relationship of the Salinas family with Cadereyta and Irigoyen, or whatever? Where can we come? These people know the answers to those questions. Those answers are going to be lost forever in a few years. So this is the time to go and dig in the memories of these people to find out what is important for you and will be important for you in the future. The second thing is that I think is very, very important. We were talking about clinical history, etc. While conventionally people go and see a psychiatrist and they make sure that nobody is listening to what they are saying and they want strict privacy, that is not something that happens with people with Alzheimer's disease. Perhaps the most important information is coming from others, not from the patient. What is this guy doing? What is the problem? How many times he has been lost? Does he get lost in the house, etc.? Those types of things. Only relatives and caregivers can give that information. Many times the person with Alzheimer's disease is going to say, I am fine. So what are you doing in the doctor's office? Oh, they brought me, or I came with. See, the person doesn't even recognize that he has a problem. So it's essentially important to get information from the family, from caregivers, or from whoever that has the information. I treat lots of adults with what is called mental retardation, but is going to be changed to intellectual disabilities. Okay. And interestingly, they go to workshops. They could live in a group home, or some of them go to their homes. You know what happens with the information that you get from the workshop, from the people that transport them, from the house they live, and from their families? They are totally different. You say, what? It's the same person. So he hits people at the workshop, but not at home. Or at home, but not at the work. Or the problem is taking the person in the van. When they get kind of confined, they get aggressive. Say, whoa, the same person, three sources of information, and information doesn't match. If you look at the Alzheimer's patients, you find that very commonly, that whatever information it comes to you is useful. No, I have something else there. You know, I usually try not to talk about my patients on their backs. But when a relative say, "Doctor, can I tell you something after we're done with this?" I said, "Sure." I know the whole story is going to come after having evaluated this person and having determined that the person is not that bad. Say, "Oh my goodness, he's doing that." Okay. That type of thing. So this issue that Dr. Fike was raising, that people actually are difficult to diagnose in the initial stages. Oh, they are difficult to diagnose. Because if they go by themselves, they're going to be one thing, and if somebody knows a lot about them, it's going to be another thing. Any other questions? We stop here. I appreciate very much your attention, and hopefully we'll come with this for this afternoon, right?
Thank you so much. Dr. Irigoyen, this is just a little thank you for coming over here today and spending some of your time with us. This is a little plaque they've given you from the Alzheimer's Association, and actually this picture that's there is painted by someone that was diagnosed with Alzheimer's.
Can I say something? You know, my name is correctly spelled with that.
Thank you so much, everyone. We're going to take a 10-minute break. It's 10:10. I'll be back at 10:20. Thank you so much.